Hi everyone. In this narration, we are going to cover GI pharmacology. So when we're talking about our GI meds, we're talking about a variety of medications that we use overlapping for a lot of your pathophysiology. So the diseases, whether you've got peptic ulcer disease or GERD, a lot of your meds are going to be the same. So first off, we're going to talk about acid controlling drugs. And when we have our acid controlling drugs, and I'm gonna scroll forward a slide here, we've got three main types of them. Okay, so you've got your antacids, you've got your H2 blockers or H2 antagonists, and then you've got your PPIs or proton pump inhibitors. And we use all of them for a lot of different disease processes, including the treatment of peptic ulcer disease. So with peptic ulcer disease, remember that the large majority of peptic ulcers are caused by H. pylori, and H. pylori is so you've got a bacterium there that is contributing to it. And so to treat peptic ulcer disease, we have to treat the symptoms, but treating the symptoms isn't going to do any good unless we also treat the cause, and the cause is this bacteria. So how do you get rid of bacteria? You give them antibiotics. And so with H. pylori, with gas or peptic ulcer disease from H. pylori, remember we're going to have to take a sample of it, right, to see what is causing it. And so we take a sample of the ulcer, and they go and they biopsy. They make sure they don't see cancerous cells or anything, but then they also check to see what's growing. So the treatment for this, we call it triple therapy, and it's a combination of medications. So you got to have an antibiotic, and a lot of times the antibiotic that they use is clarithromycin, which is the generic name for Biaxin. And then many times they add in amoxicillin, another antibiotic, and then they put you on something to treat the symptoms. So in this case, omeprazole is a PPI or a proton pump inhibitor. Now, not all triple therapy is the same. Sometimes they'll also put somebody on like Pepto-Bismol to treat the symptoms. Sometimes it's just one antibiotic. And it really kind of depends on the provider as to what they put you on. So some of the medications, they actually do it as a combination box where it has all three things in it. And those are usually pretty expensive when they package it all together like that. But most of the time you're actually going to get three separate prescriptions, or maybe two if one of them is like Pepto-Bismol that you can buy over the counter. So there's always something to treat the symptoms, which is going to be an acid controlling drug like we're talking about, and then an antibiotic. So first up, we're going to talk about our straight antacids, okay? So antacids are for acute relief of symptoms. They don't treat the problem, and they're not for long-term use, okay? So by definition, antacids are bases. So they're buffers. They neutralize the acid in our stomach, which, as we know, is hydrochloric acid. And so as a result of that, our antacids are used for a variety of problems. We've got them for peptic ulcer disease. We've got them for gastritis. We've got them for GERD. You've got it for just in general indigestion. You're going to take an antacid. And so it doesn't do anything to treat the cause, and it also doesn't decrease the production of acid. Instead, it just buffers it. It just neutralizes it. It also helps your stomach actually, it promotes the creation of our defense mechanisms in our stomach, okay? So it stimulates the secretion of that mucosal barrier that we have. And remember, that mucosal barrier is what protects the actual stomach cells, the organ itself, from the acid that is produced. Prostaglandins, so your antacids, they stimulate the secretion of prostaglandins. And remember, prostaglandins actually help to secrete that mucus barrier, and prostaglandins also prevent activation of that proton pump. So your antacids have a variety of uses here. But remember all along, though, remember that it doesn't fix the problem. Now, they're available in a lot of different formulations based on your preference. So liquids have a, like Pepto-Bismol, for example, or like Mylanta. Those have a those are very popular because it coats the esophagus as well. Okay. Some people can't stand the liquid, the chalky taste in their mouth, and they prefer to take tablets. Some people like the fizzies and they get the effervescent tablets. And so those are, and other people like to chew on it. It's really personal preference with a lot of that. Okay. Some of them are only available as a liquid. Like Pepto-Bismol is a liquid, a tablet, or a chew tab. And so you can take it all sorts of ways. Adverse effects and then contraindications. So by definition, your antacids are bases, and therefore if you take too many of them, if you're somebody who's going through a bottle of Tums every day, then you're going to be in a metabolic alkalosis, okay? And so overuse of antacids is one of the big causes of metabolic alkalosis. Antacids that include aluminum and calcium cause constipation. Calcium also causes gas. Magnesium causes diarrhea. Your calcium, because calcium is one of the things that creates kidney stones, it is often a type of kidney stone. If you overdo the amount of calcium antacids, by the way, calcium, that's your Tums, okay? So the calcium antacids can contribute to the development of kidney stones. And so somebody who's at risk for kidney stones or maybe has a history of them, we're going to tell them to take something other than Tums, We're going to tell them to take Maalox instead. This one here, potential for toxic accumulation of electrolytes. So don't forget that there is calcium in there. There is magnesium in there. And so if you are just, taking this stuff like it's candy, first off, you're probably masking a bigger problem than just some occasional heartburn. But also you run the risk of getting toxic accumulation of those particular electrolytes. And then finally, if they have a GI obstruction, so any kind of bowel obstruction, we do not give them. Because if you've actually got an obstruction and you tried, now this is not constipation. Constipation is different from an obstruction. But if you've actually got an obstruction and you try to stimulate that bowel, it can actually, you can cause, first of all, a lot of pain, but also you could potentially perforate that bowel by trying to get it to by increasing peristalsis when there's actually a blockage that needs to be surgically fixed. All right. So next up, talking about drug interactions with antacids. So this is super important. Medications are made to their dissolution rate in the stomach, the way they're metabolized, is based on the stomach being acidic at a certain level. And when you take an antacid at the same time as another medication, you're going to decrease the acidity of the stomach, okay? And so your stomach is going to become more alkaline. Now that may cause that medication to metabolize faster, or it may cause that medication to metabolize slower. Okay, so if the medication is an alkaline medication in general that is supposed to absorb or supposed to be metabolized in an alkaline environment, one of the big category there is going to be your enteric coated stuff. Your enteric coated stuff doesn't dissolve in an acidic environment. That's the whole point, okay, is that it doesn't dissolve in your stomach. And so when you have when you have a basic drug that isn't supposed to absorb in your stomach, but you take an antacid with it, all of a sudden, boom, it's absorbing in your stomach. And so now it can cause a lot of stomach upset because that particular medication isn't supposed to be in the stomach. It's only supposed to absorb in the intestine. Whereas if the medication needs that acidic environment in order to start the metabolism process, it's not going to if you've buffered all of the acid and now you've got an alkaline environment. The other thing is a product called adsorption. That's not a typo. And this basically means that the antacid, the solid, is absorbing. So with absorption, if something absorbs something else, you've got a liquid absorbing a solute, right? Adsorption is where you've got a solid that's incorporating liquid and other stuff, okay? Don't get bogged down on the difference, but basically what it's doing is that antacid is binding with the medication, and so it's covering up, it's absorbing it into itself, and now that medication can't be metabolized by the body. It doesn't get absorbed. Chelation is another thing that happens, and that is actually where the antacid permanently binds with a medication and prevents it from being absorbed at all, because it creates a different complex that isn't metabolically active. And so that medication isn't going to work. And so when we have medications like this, and when we have somebody who's taking antacids, what we tell them is you have to take your other meds at least an hour before or like 3 hours after you take an antacid. You can't take them at the same time, okay? Because that medication that you took isn't going to work. The antacid will work, okay? But the other medication is not. All right. So now our H2 blockers. So H1 blockers are antihistamines. H2 blockers, or H2 receptor antagonists, those are our stomach pills, okay? These are the tidines. They all end in tidine. And so they are used for GERD, for peptic ulcer disease, for gastritis. They're used for, we use them for upper GI bleeds. We use them for esophagitis, Zollinger-Ellison syndrome, which is when you have a tumor that secretes acid, okay? All of those things, we use it for everything, okay? And the way that they work is that they are blocking the histamine receptor that's in the parietal cells. Therefore, the parietal cells don't secrete as much hydrogen ions, which means that you have less hydrogen ions available to make hydrochloric acid. Now, your hydrogen ions are still produced because those actually come from the proton pump, okay? But with this, the parietal cells just aren't releasing as much of it, okay? So the overall effect is that your pH is going to rise, okay? Because we've got less acid, which means your pH goes up. And that's going to take care of a lot of your symptoms. Again, this is symptom management, okay? It is not fixing it's not curing it, okay? But in cases like GERD, this may be all that you need. You may not ever need anything except an occasional H2 blocker. Now, all of these end in tidine, okay? So note these. Pepsid is probably the most well-known of that. Cimetidine, nizatidine, famotidine, ranitidine. Okay, this is Tagamet. This is it starts with an A, and I'm drawing a blank. I think it starts with an A. Axid, that's what it was called, or is called. Famotidine is Pepsid, and ranitidine is Zantac, not Xanax, Zantac. And so they are all over the counter in lower dosages, and then you can get prescriptions for higher dosages. Famotidine also comes in combo, so you've got Pepsid, and then you've got like Pepsid Complete. And there's another type of Pepsid. Your Pepsid Complete, you can kind of tell here. It says acid reducer and antacid. So it has the famotidine in it, but it also has calcium carbonate in it. And so you can actually take that after you eat when you get heartburn, and it'll help with that. In general, though, with our H2 blockers, you have to take them at least an hour before you eat. So like when my dad makes chili, he has to take a Pepsid, okay? So he's like, oh, yep, we're having chili tonight. I'm going to take a Pepsid, a couple hours before I eat. That way I don't get heartburn. So that's and that's very common to only need them occasionally, okay? Overall, your H2 blockers they really don't have that many side effects. They don't have a lot of interactions with other drugs. They're very safe medications, which is one of the reasons why they went over the counter, okay? Now, we do see some CNS effects in our elderly patients, including some disorientation, some confusion. So we may want to put them on a PPI instead, which we're going to talk about. These are more commonly seen with cimetidine. Cimetidine also has the highest incidence of side effects, okay, in general. So like this next slide talks about cimetidine. We really do not give cimetidine because it interacts with drugs. When the other ones don't, it causes a lot of confusion in the elderly, and the other ones don't have as much of a risk profile there. So while cimetidine or Tagamet is still over the counter, what you'll find is it's probably the one that's least used. Okay. So cimetidine, so this binds with your P450 enzyme system. So remember that anything that is metabolized by your cytochrome P450 enzyme system, or anything that is that affects it in any way, those drugs are going to interact with each other in some way. They are either going to prevent their absorption, or their metabolism, or they're going to enhance it too much. Okay, and so you got to be careful if you've got two different medications that are both metabolized by that system. Now, as a reminder, that your H2 blockers are going to inhibit the absorption of drugs that require that acidic environment. Okay. And here's where I note it's been replaced. My dog's bellowing. But it shouldn't be given in geriatrics. Now, a couple of other things. First off, smoking has been known to decrease the effectiveness of these medications. Smoking basically increases your stomach acid, okay? And so your antacids and your H2 blockers are not going to work as well, okay? Smoking is also one of the biggest risk factors that we have for gastric cancer because it affects that stomach acid, okay? And then finally, H2 antagonists are taken 1 to 2 hours before antacids. I already mentioned taking them 1 to 2 hours before meals to have their maximum effect, but you also don't want to take them at the same time as your antacid. Now, you say, oh, but wait, that Pepcid had a combination, and it was in combination with an antacid, yes. But it's specifically formulated so that the antacid piece of it it's coded in a certain way so that you get the antacid results, but then you also get a longer acting symptom relief with the Pepcid itself, with the famotidine. All right, next up, we've got our proton pump inhibitors, or PPIs. So all of these end in prazole. So these are fairly new drugs. And when I say fairly new, I mean they've been around for like 20, 25 years, okay? Not like 50. PPIs, again, are used for a ton of different things, okay? So you've got your treatment of your ulcers and GERD and stuff like that, all that standard thing. The other thing, though, is that we also use these to treat or to prevent our stress ulcers, prophylaxism. So remember that our stress ulcers are the ones that you get if you've had a trauma and you're in the ICU, and you've got all of your blood is focused somewhere else, right? And so now you've got these stress ulcers from lack of blood flow to the digestive tract. So we give PPIs here, and the way this one works is that it actually blocks the pump that produces hydrogen ions. So remember that your H2 blockers, this should say antacids. Oh my gosh, antacids. Sorry about that. H2 blockers and antacids don't stop the action of that pump. Rather, they block it or they neutralize it, okay? This one actually stops hydrogen ions from being produced, which then decreases the hydrochloric acid. So all gastric acid secretion is temporarily blocked for that amount of time. Now, all of these drugs end in prazole, okay? So you're like, this is Prilosec and this is Protonix. But all of the menoprozol, some of them are available IV, some of them are over the counter in lower doses. They are, again, very safe drugs. They're generally well tolerated. One thing that we have found right here is, so we were putting everybody on a PPI when they got admitted to the hospital, and then all of a sudden, all of our patients got C. diff. And so we had to say, oh, okay, hey, what's going on here? Turns out that it does increase your predisposition to C. diff. So we don't automatically put you on a PPI just because you're in the hospital. But if you're at risk for a stress ulcer, we absolutely do. Okay? Now, there is a risk for osteoporosis in our long-term users simply because it affects your calcium and vitamin D metabolism. Okay? And so that's our long-term users that's in. These do have some drug interactions, which is one of the reasons that we have to be careful, especially with our elderly people, okay? And so it's your typical ones. Remember that, I'm always saying, if you're looking for something that interacts, look for warfarin or Coumadin, because that's going to be something that interacts with everything. Your seizure meds, like phenytoin, that's going to interact with it, okay? A couple of things here. Food decreases the absorption of it, which means that you have to take it on an empty stomach, okay? So typically in the hospital, these are going to be timed for like 7 a.m., okay? And then that way your patient doesn't eat right away, okay? Sucralfate may delay the absorption, and I'm going to talk about sucralfate next. Okay, so these are some miscellaneous meds. Sucralfate is a protectant. So if you've ever seen the commercial where you take a certain antacid and it coats the stomach, that is actually what sucralfate does. It provides this layer of protection on top of the mucosal layer so that the stuff doesn't hit the tissue. Okay, so we use that as a protective treatment for people when they have ulcers. Okay. Misoprostol so misoprostol is a medication that is added to NSAIDs in order to prevent NSAIDs from causing gastric ulcers. So it blocks like NSAIDs block those prostaglandins. Misoprostol stops the NSAIDs from blocking the prostaglandins. Misoprostol is also used to induce, it softens the cervix, and it also is used to induce a miscarriage. And finally, simethicone is used to reduce gas, okay? It is an anti-flatulent drug. It is often added to Tums because calcium carbonate causes gas. All right, so some nursing implications for antacids. You want to look at fluid imbalances, okay? And also like things like heart failure and kidney failure, because it will mess with your electrolyte levels. People with heart failure, so one of the classic antacids is sodium bicarbonate, but people with heart failure, we can't give them that, right? Because we don't want them to have a really high level of sodium. And so we need to be careful of giving them that, and we need to pick something else. Your other stuff, like, for example, kidney patients, they have trouble clearing the magnesium from their body, okay? And so we don't want to give them any of the magnesium containing antacids. Pregnancy, gotta be careful, okay? And we always tell people, talk to your OB. So note this, I already said this, heart failure, hypertension, no antacids with high sodium contents. Don't forget about all the drug interactions and the inability to metabolize correctly, okay? Give your meds, this is more like 2 or 3 hours after a medication, or an hour before, okay? I talked about this, your enteric-coated stuff. Chew thoroughly, shake your liquid forms well because it kind of drifts down to the bottom. And then we also want to make sure that we drink a lot of water with them to make sure that they get absorbed, okay? Another important thing here is that long-term self-medication can mask the symptoms of these, okay? And so if you've got a patient who's going through a bottle of Tums a day or every few days, and they've been doing it for a month, something's going on, okay? And this is true of all over-the-counter meds. It's, they say right at them, don't take for more than a week without consulting a provider, The other thing, watch out for some of those adverse effects that I've talked about, okay? Magnesium antacids cause diarrhea. Calcium antacids cause constipation. With your H2 antagonist, don't forget that we got to be careful with the elderly, okay? And don't take them at the same time as your antacids. For PPIs, a couple of specific things here. They come in capsules that have little granules in them, and those granules can be given via an NG tube, but the NG tube has to be big enough that the granules don't get clogged. Okay, you can mix them with some juice and kind of create what they call a slurry, but that slurry has to be able to go down. All right, that's the end of this narration. We've got some review slides that'll be in the next one.